And get started here. Before we get started, just want to let you guys know that in May, we're going to have a sort of I guess, a business session, for lack of a better word for it, sort of teaching residents about important things related to going into practice and decisions that you might be thinking about making, this kind of thing. So if you're going to go into your own practice, or even if you're going to go somewhere else, how to negotiate, how to make sure you don't sign contracts that aren't in your best benefit and things of that nature. I think it's going to be probably the second week of May, something like that. So love for you guys to be able to attend that. I think it'd be pretty valuable and give you some good information before you guys graduate. Even the younger guys, first and second years, never a bad idea to hear that kind of stuff more than once. And I'll try to make it interesting. Estate planning concepts, and we're going to try to keep it more something that's going to be stimulating and not put you to sleep within 10 seconds. So hopefully you will find that a valuable experience for you. So we'll go ahead and get started here. Anybody want to take this first one on?
I can do this one. Good morning. So looks like we have a punch biopsy here. Most of the action looks in the kind of ulcerated area in the stratum corneum. Looks at higher power, you can see in that part that's kind of separated from the punch. There's these kind of bands of peak bands of skeletal muscle. There's also that kind of light brown wall that looks like chitinous material.
What if we just had this piece over here?
Mm-hmm.
It's obviously helpful, but what if we just had this over here without that part? We'll talk about that part in a minute, but
Yeah, so here looks like a punch. There's kind of a little bit of crust and ulceration on the stratum corneum, but otherwise, on this piece, the epidermis is pretty intact. Looks like there's some like superficial perivascular lymphocytic infiltration.
And it kind of goes maybe a little bit deep also, if you look carefully at it. It's not super dense, which is kind of interesting, but it definitely is perivascular. It might be interstitial a little bit. We'll see if we go to higher magnification, but I think you're right. Most of these are lymphocytes. But let's go to higher magnification, see if there are any other kind of cells in here. Not really, surprisingly. There's really not many other kinds of cells. Here we go.
Yeah.
Now, others.
Yeah, so there it looks like there's some eosinophils in the infiltration as well.
So you know what the answer is already based on what you described before. But if you just had this piece over here, what would you think about as this pattern?
Yeah, so for this one with eosinophils in the infiltrate, I would think of also like arthropod assault.
Yeah, and notice the pattern. Notice how it's kind of a little more denser at the top than it is at the bottom. If you get a really good arthropod assault reaction, you get a really brisk perivascular and interstitial infiltrate. This kind of shows that arthropod assault reactions can kind of be all over the map. Some of them can be mostly just lymphocytic, some of them can be mostly perivascular without a lot of interstitial infiltrate. But the classic pattern is superficial and deep perivascular interstitial wedge shape. Now, this does have that kind of wedge-like kind of sort of feel to it a little bit. I mean, you see that it does a little denser at the top than it is the bottom. So that part is there. And of course, there's a reason for that, right?
Yes.
What is the reason?
Is it because of the bite that makes the wedge shape?
Yeah, but why does it give you that wedge-shaped architecture? There's a reason for it. It's not rocket science. You can see this one's kind of wedge-shaped also here. What happens in a bite? And this is a true bite, actually. Well, yeah, this is a bite. This guy's biting. He's eating. he's having breakfast, lunch, or dinner here. We're not sure which.
Mhm.
Definitely has actually bitten and attached himself into the skin here. So why do you think it's more kind of denser at the top than it is at the bottom?
Because I'd say at the bottom because it's more like thicker and densely packed is why
But
it's.
it's really more. It's almost like, imagine this guy is probably injecting some anticoagulant things here so that the blood doesn't clot, so they can suck that blood out of here and you can get a nice blood meal. And so they've got a higher concentration of those sorts of chemicals, and then they kind of diffuse more deeply. So you just think if you put a drop of ink here or dye, it would diffuse through the skin and it'd be a denser concentration here and a less concentration down here. Same thing is true if you treat a skin cancer, for example, radiation therapy or liquid nitrogen for actinic keratosis or squamous cell. The coldest parts can be up here and the warmer parts can be down here. So the higher concentration of the chemical that this guy's injecting into the skin is going to be here, and it diffuses out. So the inflammation is going to be less brisk at the bottom than it is at the top. So that it makes some sense, just kind of from a physiologic perspective, if you will. Okay. So what is the diagnosis here? What is this thing up here?
So I think it's a tick bite.
It is a tick. Okay. And if you look carefully down in this area, you can see this collagen that's degenerated and it's got this kind of bright pink color to it. That's not just sort of histologic artifact. That's actually the chemical reaction where the tick actually secretes enzymes and collagenase and has a actually fairly prominent type of glue, if you will. It forms an actual cement where this thing actually cements itself into the skin. And that's why when you yank it out of there with just some tweezers, the tick mouth parts often remain down in this area. But that's actually, and there have actually been some people that have actually scientifically looked at the chemical composition of this cement material to see if it might have some commercially available, commercially useful applications, because it really, that tick does adhere very, very strongly into your dermis like that. So you could think that maybe if you could develop some kind of a material that could be used to kind of close a surgical incision line or something like that. Okay, so you got the easy part is it's a tick bite reaction, so you recognize that. Now let's say you're the good old kind of game we play here that we're on the board examination, and so they show you this and it's multiple choice, and they have a tick bite reaction or tick, and which organism is causing this, and then what are some other organisms they might throw in there to try to kind of fool you. So when you face a question like that on the exam, you're not going to be worried about it. So what else might look, it's going to be like an ectoparasite or something analogous to this that they might put on there to try to throw you off.
Yeah. So I think other things that might look similar would be maybe scabies.
Okay, good. Scabies, and what's that going to look like?
I don't think usually that would be kind of confined in the stratum corneum as well.
It's confined to stratum corneum. Wouldn't give you this kind of thing exactly. And what about the size of the organism?
It would be much smaller.
Yeah, you're talking about probably this, that kind of size, something very small, little lesion. You can see it at low power, and it's usually a little small. It's the female mite. You're lucky if you see it in an H&E specimen. So they very well might put that on there. What's a couple of other things they might throw in there?
Maybe like a flea bite.
They might. Which specific type of flea can you actually have an organism there? So that a flea bite, you don't usually see the flea anymore. It bites you and then leaves pretty quick. But there is one type of organism in the flea family that does leave the organism right in the skin, and you do a biopsy and you can see it in there.
I'm not sure which.
sand flea,
Okay.
also known as Tunga penetrans. And that actually has got an organism. It kind of looks a little bit like a tick. It's got a chitinous exoskeleton. You can see the little legs and all that kind of stuff. And it's burrowing down into the dermis. So if you see a biopsy of that thing, it looks like the organism is nestled right down here in your dermis. And basically what happens, it takes its mouth part and it sticks it up this way. So it's got like a little snorkel that's communicating with the outside world here so it can still breathe. And it's sitting here living down in your dermis. And you see that, we do see that every now and then on a biopsy. Somebody will, go to the beach, Belize or something, and walk on the beach that's infested with Tunga penetrans, and they get these things in their toes and in their sole, most commonly, sometimes on the buttock area. So yeah, you'll see that. What's another that they might throw in there, try to fool you?
Maybe like other types of parasites, maybe like worms.
They might throw a worm in there. There's one in particular, though, that's got a nice chitinous exoskeleton like this. So Tunga penetrans has exoskeleton. Scabies has an exoskeleton that's chitinous like this. There's one other one in particular that you need to know about that also goes down into the dermis here. It's not going to be biting and sort of hanging off at the top like this. It's going to be down in the dermis and forms a little tunnel, if you will. And it does have a chitinous exoskeleton with these little black sort of rings around it that's sitting down here in the dermis. And patients often will, once again, they go to tropical areas, Belize or something like that. They come back home and they say, yeah, I got these boils on my skin, and they kind of feel like they're sort of moving around.
Is it like cutaneous larva migrans or?
Well, no, that's actually these little tiny worms, like you said before, that are way high up in the skin. They're very, very small, hard to see those.
Okay.
Myiasis, cutaneous myiasis, which is basically a fly larva, maggot that burrows down into your skin. It actually doesn't burrow. What happens is the fly bites you. The eggs are sort of hanging on the abdomen, thorax of the fly. When they bite you, they kind of fall off in your skin, and then you say, wow, that itches, and you scratch, and then you inoculate those into the skin, and then they grow in your skin. And it's actually, there is a myiasis dermatopia hominis where man is the host. Man is the target for that. There are plenty of those that are, the target is like cattle or sheep or horses and things like that. But dermatopia hominis, man is the preferred host there. So that would also not be sitting up here attached to the outer part of the epidermis, like you see here with this, it's down and it's got this cement-like area down in the dermis. It's going to be sitting in a tunnel down here. So make sure you know the differences between those. We won't go into all the diseases that can be caused by ticks, but I would highly recommend learning those too. Okay, very good.
Good morning. So here we have a punch.
Okay, good.
Biopsy. Oh, 1 second. My cat was standing on top of my television, but I rescued her. We're fine. Thank you. So here we have a punch biopsy.
Can you describe the case?
I know she may do a better job, honestly. And I noticed there were tons of cells in the dermis here.
Okay, good.
And it's kind of like superficial in the middle and kind of deeper as well.
Okay.
And from what I could tell at low power, the epidermis seemed to be doing fairly well. I could distinguish the DEJ.
Yeah, good. I agree. Epidermis looks pretty much normal. So the main problem is going on down in here. And did you think it was an inflammatory or a neoplastic process?
Well, I was flip-flopping back and forth.
Okay. Why did you flip-flop? That's okay that you flip, but sometimes you look at one of these, you're not 100% sure.
Okay.
So there's a reason that you probably weren't. Like the last case, he was 100% sure what that was. I mean, that took him about 2 seconds to figure that out. I had to figure out ways to kind of make it interesting for him. But this one, you were kind of struggling with it a little bit already. So
Yes.
why wasn't this so obvious, like the tick bite reaction?
So at first, I thought it was an inflammatory process.
Yeah, pretty
Mhm.
inflamed, isn't it? A lot of inflammation in there.
Okay.
So yeah, you might look at a low power and say, it looks like it's probably inflammatory. Okay,
That's
and then what sort of made you start scratching your head a little bit?
when I went into higher powers.
Yeah. Then what did you start noticing?
So I noticed that it was kind of like almost like one cell type, not a lot of lymphocytes or eos or neutrophils or other inflammatory cells.
What
And then
inflammatory cells were these that you saw?
so they were pretty ovoid. Um, I thought about histiocytes.
Okay, good. I agree. I think some of them do look kind of like histiocytes. If you look carefully in here,
Yes.
we may see some other cells that are of interest.
Oh,
Let's see if I
good.
can find a few of these here, maybe for you. Maybe that cell right there. It's got a
Okay.
little nuclear pallor that's kind of pink.
Okay.
Face nucleus, maybe. What kind of cell might that be?
A plasma cell.
Yeah, so maybe some plasma cells in here also. But I do agree, a lot of them kind of look like histiocytes. What else did you notice when you kind of went to higher magnification?
So well, from these cells, the nucleus was pretty large. I was wondering whether I could see more like pinpoint, like abnormal chromatin or nucleoli.
Pattern here. What about these little things here?
Okay.
These clear things that I'm pointing out to you right there.
Yeah. So they look like slit-like spaces.
Yeah, good.
Mhm.
Excellent. Good. And then
So,
what about these cells over here?
maybe more spindly.
Yes. Good.
Okay.
Good. So they kind of look like histiocytes when you first start looking at them. I
Right.
agree completely. And so what's the overall pattern of this thing here?
Honestly, I went for interstitial.
Good. You should go for interstitial mostly. That's exactly what this is. This
Okay.
is an interstitial mostly process. There are some inflammatory cells in here, and at low power, it does look very inflammatory. I mean, there's inflammatory cells in here. Now, there are also these other cells that do kind of look like histiocytes, and they're spindle in shape and slit-like. But yes, this is the interstitial mostly pattern here.
Okay.
So that throws you into a fairly small differential diagnosis.
Yes, I agree. I think I have a list of things.
Good.
Yes, good. Okay, so with the vascular slit spaces and split, oh no, slit-like spaces, excuse me. But I didn't see too many red blood cells, but if maybe that's not necessary. I would have thought about Kaposi sarcoma.
Do you think about it without the red blood cells?
Probably.
Good.
And maybe there was some.
Don't confuse a feature that's seen often or sometimes with an absolute necessary criterion for the diagnosis. So yeah, you can see extravasated erythrocytes in KS, but you don't have to. And if you
Okay.
start looking around in here,
Mhm.
it's not easy to see with this, but there are some citerophages in here. So there's not a
Yes.
lot, but
There's
so there probably were some extravasated erythrocytes at one point.
got it.
So yeah, when you see this diffuse pattern of these slit-like spaces in here, yeah, this is a good example of Kaposi sarcoma. Now, there's several different forms of Kaposi sarcoma.
Yes. I thought maybe we were at the patch.
Or maybe
Or
there's one,
plaque?
yeah, plaque. It's probably between patch and plaque. I agree. This is pretty dense for just purely patch, but
Okay.
it clinically might look like a pink, purple patch, and you feel it has probably got some substance to it because it's pretty diffuse. It goes all the way from top to bottom. It's a fairly diffuse process. Or even way down here in the lower reticular dermis, you still got some of these slit-like spaces here. So good.
Okay.
Now, what else is it, just briefly, what else is in the differential diagnosis on your list there that you had?
Interstitial granulomannulare.
Good.
Other things can include a blue nevus.
I didn't hear that. What'd you say again? I'm sorry.
A blue nevus.
They can be interstitial. Yeah, they can. I'll buy that. It's not a classic thing that we think of, but yeah, you can get those. The dendritic cells can be kind of interstitial, so that's reasonable.
How about metastases?
Yes, absolutely. Metastases like metastatic breast cancer, the single cell spread between the collegemoles, and some of the lymphomas and leukemias can be an interstitial mostly pattern. So yes, that's exactly correct. There's not too many others, so that's good. You know, cellulitis,
Okay.
you know, some things like that. So that's good. So this is KS.
Oh, good.
Now, do you need to work this up any further when you get this? If you see this pattern like this,
Mm-hmm.
you need to do an HHV8 stain here.
I don't know what I would do it, but I'm on the conservative side.
Well, if you're wanting to be conservative and save your patients some money, you don't really need to. I mean, this is so classic. It's got just almost pathognomonic features of KS. So yeah, I would not order it. In fact, when we saw this case, we didn't order it.
Oh,
So
good.
you don't need it. So that's the message, is that you see a lot of people order this. They say, oh, if you don't have an HHVH, you can't really make the diagnosis. If you have this pattern like this, it's virtually diagnostic. Okay, it's just nothing else really will do this.
Okay.
This involvement like this. So it's just a classic example. We don't know if this is an HIV positive patient or not. I think that probably clinically, in this case it was, but you can see patch plaque lesions in the classic form of KS as well as in HIV associated Kaposi, so you don't have to have it.
Mhm.
Always remember the several different other types of KS, the nodular type, the angiomatous type, there's a lymphangiomatous type. So there's several different other histologic variants of KS. That's good. Yes, very good. Excellent.
Thank you.
Okay, this is a good one. I like this because it's a teaching case here also.
Okay. So this one was a punch. Most of the action was higher up in the dermis and then in the epidermis.
Okay.
And I noticed a lot of acanthosis.
Good.
And kind of towards the bottom of the epidermis into the papillary dermis, there were on a couple of sections these more basophilic areas, kind of like going up from the dermis into the epidermis. And there's kind of like some eosinophil.
Cornified layer. Tell me about the cornified layer and the granular layer, especially in this zone right over here.
So it looks like there's a broad front of compact parakeratosis.
Is there any parakeratosis really?
Oh no, not here.
Yeah, but you're right. It is compact orthokeratosis mostly. Maybe there's a little bit of parakeratosis. It's mostly orthokeratotic. And what about the granular cell layer?
It looks hypergranular.
Good. Excellent. So what's going on here? Right here. Just what's happening here?
That looks like lichenification.
Good. Excellent. You must have this to get the rest of the process. Just so you'll know. Now you probably weren't taught that. You might have been. I hope you were, but you might not have been. You know, people believe that this disease happens sort of spontaneously. Okay. So what's going on over here?
This looks like some sort of perforating disorder.
Okay. So tell us okay, so what's the diagnosis of the perforating, or can you really tell for sure what it is?
I think it's difficult to say in this one without some sort of stains, either for collagen or elastic.
Well, let's don't go there just yet. What's the pathophysiology of these so-called perforating disorders?
I think people are just picking or rubbing and
Yeah,
they
yes. So you were taught the right thing. Exactly. And people that, so which kind of people usually pick and rub that get these perforating follicular disorders?
itchy people.
Yeah. Which type of itchy people most common?
People with renal diseases like uremic.
Yeah. Good. Yes, exactly. So the theory is that so they maybe have renal circulating prurigens, maybe they circulate and lodge in the skin, and maybe alter the chemical composition of the collagen and the elastic fibers. They're itchy, they start scratching, then they get this sort of degenerated collagen elastic that then starts getting transepidermally eliminated, and then it ends up looking like this histologically. So what we call so-called perforating folliculitis, it's almost always secondary to some kind of rubbing and scratching. If you take those people and put them in a coma and stick them in the ICU, what happens to the skin lesions?
They get better.
Yeah, usually go away. They usually kind of disappear because they have to scratch and rub these things to get this. And it's interesting, do you see this in patients with atopic dermatitis who rub and scratch their skin?
I think you can.
But it's pretty uncommon. You know, it's think of the last time you saw a patient with atopic dermatitis that actually had perforating folliculitis. It's rare. You know, they don't really get that. They get lichen simplex chronicus, they get, you know, a lot of spongiotic dermatitis with crusting and whatnot, but they hardly ever get perforating folliculitis. They get secondary staph folliculitis, but they don't get perforating folliculitis. And so when they, you know, diagnose Curley's disease, reactive perforating collagenoses, elastosis perforans spiginosa, all those conditions, they sort of need to have some kind of abnormal connective tissue component to it also for this to be recognized as a foreign body and then for it to be transepidermally eliminated when they're rubbing and scratching it. But they virtually all have to rub and scratch their skin for this to happen. And it's interesting, even patients that have Ehlers-Danlos disease, Down syndrome, and others, they probably have some kind of altered collagen and elastin for this thing to happen. It's not just something that happens spontaneous, like, you know, so-called spontaneous keloids. And they used to talk about that years ago. Well, that's always related to some kind of underlying inflammatory process, folliculitis or acne or something. So this is the same thing. If you don't see this prurigo nodularis component, you're not going to get this. And it's probably not that critical to distinguish between or among RPC and elastosis perforans collagen. You're going to see degenerated elastic fibers and collagen fibers in this area here. Here's some dystrophic calcification of probably elastic fibers and collagen bundles in here also. So that's pretty straightforward. So I think that's the teaching point in this case, is that recognize it's basically just lichen simplex chronicus, prurigo nodularis, plus this transepidermal elimination. They're not going to ask you on the board examination to distinguish between reactive perforating collagenoses, perforating folliculitis, any of these things. They might ask you, this is a perforating disorder, which disease is it associated with, or, you know, something like that. Okay. Any questions about this thing?
No, that was great. Thank you.
Okay. This next one. Best one of all here.
Okay, so this looks like a punch, and I think the first thing that caught my eye was that the epidermis looks fairly normal. I think most of the actions in the dermis.
Okay.
The first thing that came out was just like this large amount of the large amount of hemorrhage with all these RBCs.
That's probably artifact, just so you know. You know, that's
Oh,
probably
okay.
a secondary at the time of the punch. Patient just bled a lot into the skin. So that's probably just ignore that.
Gotcha. Okay. You also see like a lot of this, like lots and lots of this collagen also. Like some really thick collagen bundles.
Think that's the pathology, or what part of the body do you think you're on?
I think maybe on the trunk.
Yeah. Yeah, it's probably trunk, could be proximal extremity. It's a
Mhm,
really good biopsy. They went really deep here.
mhm,
And it's just, yeah, it's probably an area where the skin is really thick.
mhm.
So do you think it's an inflammatory or a neoplastic process?
I think inflammatory.
Yeah. This one's not as easy as some of the others we've had today. So what's the pattern here?
Let's see, the upper dermis, you kind of see, I think, is that lymphocytic inflammation?
Good.
Uh,
Yeah, you get a superficial perivascular infiltrative lymphocytes, most likely. They're black at
Yeah.
low power. So yeah, lymphocytes. Okay. And not really, maybe a little bit down here around these adnexal structures, but it's mostly superficial perivascular dermatitis, which is the most difficult to be specific because lots of different diseases can cause that pattern.
Mm-hmm.
So that's why it's probably going to be, you're probably not going to be able to come up with an absolutely specific diagnosis as compared to the tick bite reaction, for example, which is pathognomonic. Here you're going to have a differential and say based on A plus B, it's possibly going to be C. And then you're going to have to correlate it with the clinical information. So it's got superficial perivascular dermatitis. Is the epidermis normal or is there some abnormality to it?
I don't really see much.
It's a little bit acanthotic, but I agree. It's not dramatic at low magnifications. Let's go to higher magnification, see if we can see anything here. So I think higher magnification, it bears out what we saw. These are mostly lymphocytes here.
Mm-hmm.
We're going to look, there might be an eosinophil there. And then we're going to look carefully in the epidermis. And you've got some pycnotic nuclei here. And perhaps some dyskeratotic keratinocytes in here. This is really subtle. Pretty
Mhm.
subtle. So we're in trouble here, right? You know, we're not going to be able to make a specific, absolutely 100% diagnosis. We're going to be able to suggest some things. So what kind of things are we going to think about here? There are a couple of EOs.
Let's see. You think of conditions like maybe like an arthropod related thing or
What could be, but we had the arthropod before, and we
Mhm.
talked about that being wedge shaped. This really isn't wedge shaped here, is it? It's more superficial perivascular.
Mm-hmm.
It
So maybe
does
like
have some EOs,
Denver
so you might say,
process.
well, you know, maybe it's a weird bug bite reaction. It'd be unusual, but
Mm-hmm.
you throw it in there, you at least think about it. What else do you think about? What's the most common
Like
superficial vascular dermatitis with some lymphocytes and eosinophils like this?
an eczematous process.
But there's not a whole lot of spongiosis, right?
Yeah.
So when you say eczematous, what do you mean when you say eczematous? Eczematous is almost, my old mentor, Dr. Ackerman, used to have a term he called Pirandello-esque.
Mm-hmm.
Pirandello was an Italian playwright that had a play that was titled Right You Are If You Think You Are. And so basically he would say, we call something Pirandello-esque, but somebody just said, well, that's what I think it is, therefore it must be right. So eczema is kind of the same thing. You know,
Yeah.
what do you mean when you say eczema? You know, because it's basically, and I agree with him because it's sort of a wastebasket term that people use for a lot of different things. And histologically, when you biopsy eczema, what do you see? When you say eczema, what do you mean? You mean atopic dermatitis?
Yeah, or just some sort of like a contact dermatitis of sorts.
So you mean basically a disease when you biopsy, it's going to show histologic features of spongiosis.
Yeah.
They can show usually kind of subacute spongiotic dermatitis. Usually, if you biopsy atopic dermatitis, it shows a little bit of spongiosis, a little bit, you know, some psoriasis from hyperplasia, you know, that sort of thing. But that's one of the reasons I don't like eczema is because, you know, a lot of times these things, stuff that says rule out eczema. Well, do you mean like contact dermatitis or do you mean atopic dermatitis? Well, those are two different ball games altogether. One guy needs patch testing. You know, one guy needs dupilumab, you know, so I don't like it because I'd rather say rule out atopic dermatitis. And if it shows that histologic finding, then I can say it's consistent with that. If they say eczema, it could still be contact dermatitis. So that's why I don't like it. It's not precise. So, yeah, what you're saying is it could be a variant of one of the spongitis dermatitis, and I would agree with you. It could be that. It could be atopic dermatitis. It doesn't have quite the epidermal hyperplasia that we see, but what if it's partially treated atopic dermatitis? So that could definitely give you this pattern. It's got a couple of dyskeratotic keratinocytes, which is a little funny for that. Usually don't see dyskeratotic cells in atopic dermatitis. So that'd be a little funny for that. But what's another condition that's very common?
Maybe
we
like
see
maybe like urticaria or like a drug react or like a
drug
hypersensitive.
reaction. Drug reaction. Now, if you're one of these kind of people that likes to be right all the time in a conference, you can always say a drug reaction in syphilis, and you can always be correct. You can pat yourself on the back that I got the answer right. Might not be real what's going on in the patient, but at least you're right from the standpoint of differential diagnosis. So the message there is you should always think about drug eruptions. You should pretty much always think about the possibility of syphilis. I wouldn't think about it too likely here, but those two conditions can give just about any histologic pattern. If you don't see plasma cells, it's probably not going to be syphilis. You do not need one single eosinophil for a drug eruption. So you don't have to have EOs for drugs, even though people say that. But the fact that this has some dyskeratotic keratinocytes, superficial perivascular dermatitis with EOs, I would put a drug eruption fairly high in the differential. And if you get dyskeratotic cells that are scattered, what might cause that as opposed to just another garden variety type of drug eruption? This is a more difficult guess what I'm thinking kind of question in a way.
Like a chemotherapy agent?
It's a good idea, chemotherapy. Actually, chemotherapy, you'll actually, and those really aren't hypersensitivity reactions. You'll sometimes get a so-called squamatization of the basal cell layer. Don't really see much of that here. But what I was getting at was a phototoxic drug reaction, a drug reaction that's maybe flared by the light will tend to give you more dyskeratotic keratinocytes sometimes. Sometimes you get confluent epidermal necrosis. So there's no really way to tell that here. So that's the whole point, just getting it into a differential diagnosis, having a differential diagnosis, and then looking at the clinical information that's correlated with it. They probably are not going to give you something like this on the exam without a lot of clinical information. It's too hard. There's no way you get a specific answer on this. But like you did, you can get it into a differential. So you excluded a lot of stuff, which is good. Differential diagnoses should not be like laundry lists. They should be short and sweet. The best differential diagnosis is 1. The second best is 2. You don't want it to be 20 things. So you keep it short and sweet like you did. So that's a good approach to that.
Yeah.
This one's another good one here that you can get, I think.
So this looks like a punch, and in the epidermis, you can see that there is a pustule. It looks intraspinous layer, and it's filled with neutrophils on higher power.
Good. What about the infiltrating the dermis?
There is like a mild infiltrate. It also looks like neutrophils and lymphocytes.
Okay, so notice the difference between these cells and these cells at this power. So I don't want you don't have to become an expert at identifying inflammatory cells at low power, but can you tell the difference between these two? Don't they look a little bit different? You're right, these are neutrophils, and these are like black, like the last case. These are lymphocytes mostly. You can tell they look different at low power. So you can just say, there's a lymphocytic infiltrate in the dermis, and then there's neutrophilic infiltrate that's intradermal, and it's right in the intraspinous area, like you said. I bet you there's going to be some EOs in here, interestingly enough. And sure enough, here's some polys here. These are lymphocytes mostly. They're admixed with some neutrophils. And there actually are a couple of eosinophils here and there scattered in this. Not so many, but there are a few. Okay, so this differential diagnosis is very small, isn't it?
Yes. I also saw some acantholysis
Good.
And so because of that, things on my differential were Pemphigus Foliaceus.
Okay.
I also thought about staph scalded skin syndrome. Um,
Staph scalded skin. Okay, so when you say staph scalded skin, what do you mean by that in general? What's going on with staph scalded skin?
there's that toxin producing bacteria, and then
Yeah. And it basically targets desmoglein 1, I believe, just like the autoantibodies that do in superficial pemphigus. And so it basically looks histologically the same. But why staph scalded skin if this is just one little small blister here? Does it have to be staph scalded skin if it's bacterial?
no, it could also be impetigo.
Yeah, yeah, it could just be garden variety bullous impetigo. So you don't necessarily have to jump to staph scalded skin when you see this. I probably wouldn't jump to staph scalded skin. I'd probably say, well, it's a subcorneal pustule with acantholysis. It could be bullous impetigo if it's widespread over large parts of the body, staph scalded skin. And how many, you've seen patients with staph scalded skin in the neonatal intensive care or whatever. Do those patients have pustules usually?
No.
No, their whole skin is like eroded, right?
Yeah.
So this wouldn't look that great for staph scalded skin. It'd really be better for bullous impetigo. Same concept, just a little bit more precise. Okay. And what else would you put in the differential? So you're riding high here. You say, okay, this is superficial pemphigus. I'm ready to move on to the next question. But it's multiple choice. You look down there and let's say they have staph scalded skin. And then you're going to say, well, it's just a small blister with a pustule. They don't usually get that in staph scalded skin. And then they got herpes virus infection in there. This be herpes?
Sorry, what was the question? If it
Could
could
it
be
be
herpes? Yeah, I guess it could be. I don't know if you'd see that much inflammation.
You can. You see pustules with herpes infection. So yeah, it could be theoretically with the neutrophils, but what about the cytologic features of the cells? This could theoretically be fair game. If they really wanted to get tricky, they could put this in there. This would be a hard question if they put it, because you have to be able to look at these acantholytic cells and be confident these are not viral cytopathically affected cells. Would you be confident of that?
Probably not. I guess I don't know if those are more pink and
Well, they can both look kind of necrotic like this, but notice there's no multinucleated epithelial giant cells. These cells are just kind of dead. There's really no margination of the chromatin. It's just, you've got these, you don't have any Cowdery bodies, not anything like that. So that'd be a hard question. They'd have to be really, really in a bad mood to put that on there. But no, this would not be herpes infection, but it is acantholytic. So that's true. Could this be pemphigus erythematosus?
yes, it could.
But is that the best answer? Now, that's another one they'd have to be super sadistic to put that in there. Why is it not likely to be pemphigus erythematosus?
I was thinking that I thought that mostly presented on the face, and this kind of looks like it might be on someone's back.
Well, they could both be there. That wouldn't necessarily do it. What do you see in pemphigus erythematosus? What is pemphigus erythematosus versus pemphigus foliaceus, or Fungo selvagem for that matter? What's the difference between pemphigus erythematosus and the other forms of superficial pemphigus?
It has other features of lupus.
Yes. Yes, they have an interface dermatitis plus this. So for this to really be a good diagnosis of pemphigus erythematosus, they should have features of lupus plus this. We don't have any features of lupus here, right? We've got no interface change. So that would be not as good of a diagnosis as the pemphigus foliaceus type of superficial pemphigus. What about subcorneal pustular dermatosis? They might throw that in there if they're really going to be a very hard question. They might put that in there. Why would this not be good for that?
Would that have more like neutrophils in the dermis?
Well, you get neutrophils in both, but here's the answer. Do you see these cells in subcorneal pustular dermatosis?
No.
No, you don't. You don't get acantholysis there. You get spongiform pustule formation, and then you get the neutrophils beneath the cornified layer, and you get the pustule that forms there, but you don't get acantholysis in that condition. And the last thing they might throw in here would be like a fungal infection, like a tinea infection. You can get a subcorneal pustule in that too, but you're not going to see acantholysis in that condition. So this is superficial pemphigus, not pemphigus vulgaris. Notice how superficial the blister is. It's right where you said it was, right in the interspinous intragranular area. Sometimes if you get a biopsy, this is a beautiful biopsy here, but sometimes you'll actually look at the edge of the specimen, like right over here, and you kind of get a Nikolsky sign that gets formed when they do the punch biopsy. And can you see the little acantholysis that's going on right here? That's actually not an artifact. That's actually probably was produced when they did the punch. They probably didn't actually have a pustule here or a blister here, but actually if you're looking at a biopsy of pemphigus vulgaris or whatever, look to the side and you can often see that. Another clue is that you get involvement of follicles with true pemphigus. You get follicular involvement and adnexal involvement that you don't see in Grover's disease. You don't get as much of that in this specimen here, but that's very commonly seen in pemphigus versus the pemphigus type of Grover's that can be focal. Okay, very good. All right, this one's a little harder.
Good morning. I'll take this one. I agree. This was a little bit difficult for me.
Yeah, it's not a good biopsy, unfortunately.
But we've got a superficial shave. And then at this power, kind of two things stuck out to me. Looks to be maybe like ulcerated or necrotic on the surface here, with some crust. And then on the left there, just, lots of edema within the epidermis, maybe a vesicle formation. You were kind of showing like loss of the DEJ, I think, when we were over there as well. So starting with like kind of the top, I kind of narrowed in to try to see exactly if, potentially it was like epintigenized. I did see some inflammatory cells, but it was difficult to appreciate, at least at the very top, what they were. But actually kind of going down, I thought it was more of a mixed infiltrate within the papillary dermis. So lymphs, neutrophils, and I believe I saw a few EOs as well.
Yeah, exactly. Everything you're describing is absolutely correct. So we've got an ulcerated lesion. It looks like that. Do you think this is all secondary ulceration and it's trauma and it's factitial, or do you think there could possibly be some sort of primary process that's leading to this? And maybe look kind of right in this area. That might be a clue, but this is challenging because it's a shave biopsy of a lesion that's inflamed and ulcerated, and sometimes they do this because they think clinically that they're neoplasms, and they're not neoplasms.
And so that was part of the difficulty was, I thought this was more of an inflammatory process. And I didn't think it was likely, if someone had a rash that they would do just a shave. So I was trying to think of maybe just a single lesion that they may biopsy. One that I had was potentially like arthropod, or maybe like a severe like contact dermatitis that would cause this much like inflammation and spongiosis. And maybe a little bit of this ulceration.
Do you like when you say contact, you mean allergic contact or maybe kind of irritant contact?
More of like an irritant contact is what
I
was
thinking.
thinking.
I would think this is going to be a contact process. It'd probably be some sort of an irritant reaction. I agree with you. Now, if you look at this area, this is challenging. So I'm not going to, they would never give you this in the board examination. This is just one of these examples of the case we saw. We wanted to share with you, but it's not great. Notice that in this area, you've got these sort of gossamer strands of probably fibrin, maybe collagen. You got neutrophils here.
Mhm.
Carefully at these residual keratinocytes, they're dying. There's maybe some fluid collecting inside the cells here.
Like some like ballooning of the
There's some ballooning.
reticulization. Right.
And this is extremely hard. So don't think that you should have figured this out. It's very challenging. So
I did kind of,
it is ballooning degeneration.
so I kind of tried to go down like each of the differentials, like first like with this necrotic area and then like, you know, how much edema, but I thought maybe like viral would be a potential cause. So maybe like a Coxsackie virus, because I didn't, you know, find any sort of like inclusions when I was looking. I didn't see any changes that looked like herpes. So I was thinking maybe Coxsackie was on the differential as well.
It would be in the differential, and so that's good. I'm glad you thought that. And you know, you can see how just irritated and eroded and crusted this is. And this is, I apologize, it's not a really very good example. But yeah, you're right. If you identify the reticular alteration, the ballooning degeneration, then that's fantastic that you did that. That cell there you can see has got a little bit of viral cytopathic effect in there. It's very, very subtle.
Okay, yeah.
And, this was a patient that had probable had Mpox infection. We don't have a lot of examples of that, so we wanted to share with you. But this is what you see in the real world when somebody has like 1 or 2 lesions and the clinician thinks it's something like a basal cell. I'd say probably the most common setting where we see this is on the nose or the lip in an older person, and it's shaped, sending into us as roulette basal cell. It's crusted, it's oozing, you know, it's an ulcer that doesn't heal, which is the clinical, you know, feature of a basal cell in many cases, or squamous cell carcinoma. And they shave it, and you look at it and say, well, there's no cancer here. There's all this crust and inflammation. You start looking at it and say, well, these cells are dying. Maybe there's some of them, maybe a little acantholytic. And you say, we send this out as consistent with late stage possible herpes infection. We're not sure. Sometimes we'll actually see real viral cytopathic effect up here where the cells are dead. And then we can say that it's most likely a chronic herpes virus infection. And you'll see that clinically. You'll be fooled. You'll think it's a basal cell and you'll shave it, and sure enough, it comes out as something like this. So from a teaching perspective, it's good for that. I don't think we can call this definitive pox infection, but you can kind of, like you suggested, maybe it's viral. It's got reticular alteration. It's ulcerated. Maybe these cells are dying here. So we can't be sure. A lot of times we're not sure. But we could say in the context of a clinical impression, maybe it is Mpox infection. And I think that we had somebody submit this. The patient apparently had multiple lesions. We called up the clinician and we sort of figured it out. And we sort of suggested that maybe it is Parapoxvirus infection. I don't know if it was Mpox, it might have been ORF or Milker's nodule. But this is what these things look like when they're ulcerated like this. So that's good. I mean, in something like this, that's about all you can really do. So that's you got it into that differential.
Awesome. This was fun.
But this one is diagnostic.
I guess I can take this one. So here we have a shave biopsy of a largely dermal neoplasm, and just immediately noticed like kind of the papillary projections into a cystic space, and seeing kind of like some endothelial cells on higher power that look like they have like glandular differentiation.
You said endothelial cells, or maybe I misheard you.
Epithelial cells?
Epithelial. I'm sorry. Okay, great. So you think it's a neoplasm?
Yes.
Epithelial neoplasm. And benign or malignant based on what we see here.
So I was trying to decide if this was like well circumscribed or not. I think it's decently well circumscribed, but some of the cells on higher power seem to have like maybe some mitoses, which I know can be normal in benign tumors as well, but largely well circumscribed. So probably benign.
It's hard to be sure, but like we kind of say, this is, you know, if we drew a circle around, it's probably going to go right here. It seems to be pretty symmetrical. So I agree with you. I favor benign on this. I agree it's got glandular morphology. So we're thinking in dermatology, what kind of glands do we see that are commonly found adnexal glandular structures in the skin? What are the three main glands that we see in the skin biopsy? Which of those?
Right. So we can see like apocrine glands, eccrine glands, sebaceous glands. So this looked more like apocrine differentiation.
Apocrine differentiation. And why would you say that?
You can see kind of the little pieces almost like being lifted off like hats and floating into the lumen.
Yeah, you got the classic decapitation apocrine secretion.
Mhm.
Good. I totally 100% agree. So once we've got into that category, we're in the, we've gotten it into the menu, if you will. We know what restaurant we're in now. Now we're going to be more
Right.
specific and state which of the apocrine lesions are we dealing with? And is there anything here that helps you with that?
Right.
So
So
there's not a lot
definitely,
of apocrine lesions that you have to deal with. There's maybe only about 5 to 7. And which one do you like here of those 5 to 7?
I was between 2 to 3, but I think my favorite was Hydranoma papilliferum for this one.
Okay. What's the other one that's pretty close to that histologically?
Yes, the other one I was between is the Syringocystadenoma Papilliferum or SCAP or
Okay, and
SCAP. Mhm.
what kind of helps you distinguish between those two?
Right. So on some cuts or pieces, the lesion was completely, separated from the epidermis, but in this one you can see it is connected with the epidermis, so that leans more towards SCAP, whereas Hydranoma papilliferum is almost always kind of hidden from the epidermis.
Good. I agree with you completely. What about the location?
Yes, so location would be really helpful because if they said this was like maybe a forehead or scalp lesion, I would lean more towards scalp. And if it was like a vulvar lesion, I'd lean more towards Hydranoma papilliferum.
Exactly. And the other thing too that you often see with hidradenitis papilliferum that you don't see with this is you get a lot of plasma cells in the interstitium.
Mhm.
We don't see there. So this would favor Syringocystadenoma Papilliferum. I totally agree with you on that. So good. And of course, you know where we see those most commonly.
On the scalp and forehead.
In what setting do you see those?
In usually younger patients, like children.
Yeah, they're usually associated with nevus sebaceous, interestingly enough. So
Yes,
we
yes.
see a Syringocystadenoma Papilliferum component to that. So this one doesn't look like it's got any nevus sebaceous associated with it. And it
Mm-mm.
looks like if it's on the scalp or forehead, they rubbed the heck out of it. So maybe it was
Right.
itchy or something like that. So yeah, it's kind of an interesting lesion. So we have 2 minutes. Anybody want to give this one a go in 2 minutes or less?
I can do this one. So it looks like we have a shave of a fairly well demarcated looking like nodule located in the dermis.
I think it's a nodule.
Or I guess papule. It's pretty small.
Yeah. What part of the body are you on?
Yeah, there's a lot of hair follicles here, so I was thinking maybe we're somewhere like on the scalp or a hair-bearing area.
Yeah, it's maybe the nose.
Yeah,
Little sebaceous gland there, dilated blood vessels. You
yeah,
said it's low power. What's your diagnosis?
on low power. So this one I was a little struggling with. So there's kind of like spindled cells here. So I was trying to figure out what kind of like spindly cells these are. There are some like dilated blood vessels here.
Blood vessels. What kind of and what's going on here in the stroma?
So I thought these could be maybe like fibroblasts or like maybe like
Yeah,
neural
fibroblasts. So
fibroma.
angiofibroma. But what's interesting about it? What's going on over here in this component?
So let's see.
See, these cells have this kind of bluish gray granular cytoplasm.
Yeah, I'm not sure.
It's a variant. So this is a so-called granular cell angiofibroma.
Oh,
It's a variant of an angiofibroma. There's about, maybe 5 or 6 variants. You can get angiofibromas that you see in tuberous sclerosis, but you can get these granular cell degeneration in some of the cells in an angiofibroma. It's just a histologic variant. It doesn't mean anything. It's not granular cell tumor. You can get granular cell changes in lesions other than granular cell tumor, like this, atypical fibrous lymphoma. We can see granular cell leiomyomas. So there's like about 5 or 6 different entities where you can get granular cell degeneration, and an angiofibroma is one of them. I doubt seriously this is going to appear on the board examination, but it's just kind of a histologic interesting entity. So just remember that you can see granular cell differentiation in situations other than granular cell tumor. And this is just a granular cell angiofibroma. Okay, very good. Good job, everybody. And we will see you guys next month with another set of unknowns. So have a good week. Have a good month.
Thank you.
Thank you, guys.